Hello and welcome to this session on prescribing in the Children's ED at Leicester Royal Infirmary. In this session we're going to focus on a few safety principles around prescribing in Children's ED. The session is based on a learning module originally designed by the London School of Paediatrics and the Royal College of Paediatrics and Child Health. The main objectives for this session are to understand the need for safe prescribing in children, to understand the key differences in children that make them at particular risk for prescribing error. We've got some suggestions for good practice backed up with some examples of common scenarios that you might encounter. So why are we focusing on prescribing in Children's ED? Well, because prescribing errors are common within all grades of doctors, both in a hospital setting and in the community, but the risk of prescribing error is increased in stressful environments, and the emergency department counts as one of those at times. Prescribing errors in children can lead to significant harm and can even be fatal. Prescribing for children is different to prescribing for adults. So different how? Children differ in many significant areas when compared not only to adults, but also when you compare to other children at different stages of development. The neonate is different to the toddler, is different to the school-age child, for example. Children differ in size, obviously, but also anatomy, physiology, pharmacology, and crucially psychology compared to adults and other children. With that in mind, there's a number of aspects of paediatric prescribing we have to consider. Many medicines come in a number of different preparations: oral suspensions, tablets, suppositories. We need to think which is best for the patient group that we're dealing with. Different preparations have different concentrations. A good example being Calpol, which comes in liquid form of 120 milligrams in 5 mils and also 250 milligrams in 5 mils. And we need to specify which we're using. The dosing we'll come to in due course. We need to be mindful about generic and trade names for a number of medicines which can cause confusion. And we work across the full spectrum of units, sometimes dealing in micrograms, milligrams or grams, so the capacity for 10 or even 100-fold error exists in our population. Finally, we need to think about administration of medications, many of which don't taste particularly well, and often children are not particularly willing or easy to reason with. Subsequent to the ED care, we need to think about whether there is going to be a compliance issue with any treatment course that we initiate. When we're calculating drug doses in paediatrics, we're most often going on the weight of the patient or their age. Very occasionally we need to calculate their surface area, but we have ways to do that. When we calculate a dose, we won't go above the adult maximum dose. Doses are available in the BNF for children, which is available in paper form and also online and as a free app. Most drugs that are mentioned in any of our clinical guidelines will come with doses in them. And then again, there are approved resources such as posters for critical care infusions or other national guidelines available throughout the department. So obviously, wherever possible, we want the patient's actual weight recorded as soon as possible. And this is usually pretty straightforward, and it's the most accurate way of determining a safe medication dose for your patient. However, it's not always straightforward, and in an emergency, we often estimate the patient's weight either by using formula from APLS and the Advanced Life Support Group, plotting them on charts, or using various paediatric emergency apps. And we can talk more about that sort of thing face to face. We also have a drugs calculator that can be found on the Paediatric ED pages of Insight, which calculates lots of useful research drugs for you. Most of the time, you're going to be prescribing medications on the back page of the patient's notes, the ED drug chart. It's really important to make sure that the patient demographics, the allergies and the weight are filled in to make this prescription legal and safe. If we admit children, it's part of the single front door pathway that we complete a children's hospital drug chart before they go upstairs, even if it's just the front page. Less commonly, and depending on the clinical scenario, we might also prescribe on antibiotic-specific charts like gentamicin and vancomycin. We may utilise critical care charts for children being admitted to CICU or HDU, and obviously if giving blood products, we would use the Children's Hospital blood transfusion chart, all of which are available in the department. So if we run through some really basic examples, on this occasion let's look at weight-based prescribing, and let's take Nevaeh, who is 4 months old. She weighs 5 kilos and she requires IV ceftriaxone for suspected sepsis. The dose can be found in multiple places, the easiest being the sepsis grab box, which contains all of the drugs needed as well as the guidance on how to prescribe it and administer it. So in this case, we're looking for ceftriaxone at 80 milligrams per kilogram per dose once daily. The patient weighs 5 kilos, so that's going to give a dose of 400 milligrams and a prescription that would look something like this. Now if we look at another example, this time for age-based prescribing. Little Romeo is 2 years old, he weighs 12 kilos and he needs oral paracetamol for his pain. Again, dosing is available in multiple areas. On this occasion we're looking at the BNF, which has a whole range of age-based dosing options. And if we have a little look at the specific age, for children 2 to 3 years, it says 180 milligrams every 4 to 6 hours, maximum 4 doses daily. And so we would prescribe, and it would look something like this. If we move on to think about writing up infusions in children, infusions fall into 2 broad categories. The commonest infusions we prescribe are IV fluids for various reasons. Less commonly we'll prescribe drug infusions, things like salbutamol for severe asthmatics or insulin and DKA. The doses and the calculations for drug infusions can be found in the guidelines that are specific for those conditions, or also on Insight and on the CICU drug posters that we have around the department. But we'll leave them from this point in this video and focus on IV fluids, which is much more common. So if we're thinking of prescribing IV fluids in children, the key considerations are why are we giving IV fluid and what fluid would be appropriate in this scenario. So if we look at the why, it's all about the indication, the clinical context in that situation. Are you treating shock? Are you treating dehydration? Or are you running fluid maintenance because the patient won't be able to keep up via the enteral route? Similarly, the choice of fluid depends on the clinical context and the indication. And the options available to you are normal saline with dextrose, 10% dextrose, and the above fluids with potassium added or without. In terms of blood products, again, that's something to leave for another day. If you need to prescribe an IV fluid bolus, then the question why helps answer the question what. For example, if we're treating shock in a neonate, then we would give 10 mL per kilo boluses of normal saline. In older children, we would give 20 mL per kilo of normal saline. In trauma, we might give 10 mL per kilo of normal saline, but we would want to use blood products as soon as they are available. In hypoglycemia, we would give 2 to 5 mL per kilo boluses of 10% dextrose, followed by a maintenance infusion. So in this example, Peter is 5 years old, he weighs 20 kilos, and he has suspected sepsis, and he is clinically shocked. So he's tachycardic, he has low blood pressure, and very poor perfusion. So the question why give a fluid bolus is answered. He's in shock, he's got sepsis. And the question of what is normal saline at 20 mL per kilo. His prescription would look something like this. Lastly, we come to IV fluid maintenance. So the question why and the question what still apply. Generally, we would use normal saline with 5% dextrose, a fluid that is isotonic, not hypotonic, but also has some calories in it. The clinical context and the guidelines may specify other fluids and additives depending on the clinical condition though. And for example, the DKA guideline or in certain metabolic patients with their own specific care plan, and newborns, particularly in the first week of life, all have slightly different fluid requirements. If you're ever in doubt, ask a senior for advice. When it comes to calculating IV fluid maintenance, there's a couple of different ways. We suggest using the formula you can see here. So calculate 100 ml per kilo per day for the first 10 kilos, 50 ml per kilo per day for the second 10 kilos, and then 20 ml per kilo per day for every kilo after that. Adding all that together gives you the daily fluid maintenance requirement. Dividing that by 24 gives you the hourly infusion rate. So in this example, Abby is 10 years old, she weighs 35 kilos, and she's been put nil by mouth while she waits theatre with suspected appendicitis, so she needs fluid maintenance. The first 10 kilos at 100 ml per kilo per day generates 1,000 ml. The second 10 kilos at 50 ml per kilo per day generates 500 ml. And then at 20 ml per kilo for the remaining kilos, that's 15 kilos, generates 300 ml. Adding all that together gives you a 24-hour requirement of 1,800 ml. Dividing that by 24 gives you an infusion rate of 75 ml an hour. As I'd said, our standard choice of fluid would be 0.9% saline and 5% dextrose for maintenance requirements, and that comes in 500 ml bags. So that prescription is going to look something like this. And when it comes to calculating the rate, it's absolutely fine to show your calculation somewhere or work it out on a piece of paper. If we pause to think about dehydration, sometimes it's necessary to give additional fluid to IV maintenance in those who have losses. The first question is always, is IV rehydration required? Much like, is IV maintenance required? Because the enteral route is always safer, but not always tolerated. So that said, the NICE guidelines for D&V in children offer a simplified approach to the assessment of dehydration and prescribing of additional fluid. They say, if there are signs of dehydration, give maintenance fluid plus an extra 50 ml per kilo over 24 hours. If there are signs of shock, treat shock. So following resuscitation, you then give maintenance plus an extra 100 ml per kilo for 24 hours. This guideline informs our own gastroenteritis guideline that you can find on Insight. Patient safety is absolutely paramount. And so, if you're ever in doubt around a paediatric prescription, please ask a senior for some help. In terms of important do's and don'ts, they're both pretty generic and applicable to your practice wherever you're working. Do know what you're prescribing, do know why you're prescribing it, and if you can, step away from the clinical area to write that prescription. Utilize one of the desk spaces or clinical workstations. Wherever possible, don't interrupt others who are prescribing or get interrupted yourself. Don't be a checker for your own prescriptions. And again, don't ever be afraid to ask. So to summarize, it's crucial to understand the need for safe prescribing in children's ED. There are key differences in children that we need to consider when prescribing. We've offered some suggestions for good practice and backed them up with some examples of common scenarios. Further information can be found on Insight if you click the red button and look at our clinical guidelines. And there are also some recommended national learning modules available here through the RCPCH and the e-learning for health platforms. And finally, if you have any further questions or suggestions, please get in touch. I'd like to thank the Royal College of Paediatrics and the London School of Paediatrics for their work in this area. I'd like to thank those who have written the UHL guidelines. And I'd like to thank you for listening to me and I look forward to working alongside you, Sue.